Great. Lovely. All right. I think we'll get going now. My colleague, who was meant to do the opening karakia, is unwell today, so I'll be doing it in her stead. So please forgive my poor pronunciation, but we'll kick off with that. So, ki hora te marino, kia whakapapa punamu te moana, he huarahi ma tatua, I te rangi nei, aroha atu, aroha mai, tatu ia tatu katoa, huie taikie.
Yeah.
So that's may peace be widespread, may the seas be like greenstone, a pathway for us all this day. Let us show respect for each other, for one another, bind us all together. Okay, well, thank you all so much for taking the time out of your day to join, and a huge thank you to our presenter today, Melanie Gibson. We will hear from Dr. Gibson in just a moment. I just have some quick housekeeping. We have a great sort of calendar lined up for this webinar series moving forward. So I encourage you to all check out those upcoming presentations. We have kind of a special panel online discussion that's taking place not this coming Monday, but the following, the 30th of March, where we'll have a panel of people talking about advocacy around relationships and sexuality education. So you'll be receiving an invite for that, and I hope you can join to sort of think about how we get more people involved in this area of education that we know so many people care very much about. It's currently under review by the government. So there's that coming up, and then we'll be hearing from others later on this year. And as usual, if you have suggestions, ideas of people that you think would be, want to and be interested in sharing their research or their work in sexual and reproductive health over the live course, please get in touch. Or if you yourself would be interested in doing that, please send me an email. So this session is being recorded, and I'm now going to introduce our wonderful speaker, Dr. Melanie Gibson. She is an associate professor at Te Punahauara, the School of Health at Victoria University of Wellington. She has been involved in research addressing a wide range of topics across sexual and reproductive health, including polycystic ovary syndrome, premature menopause, perinatal mental health, pregnancy care, and cervical screening. Melanie's public health research aims to increase equity in women's health and improve the provision of comprehensive, person-centered healthcare to women who experience significant barriers to attaining their full health potential. She does this by addressing evidence practice gaps important to women and their healthcare providers. She invests in stakeholder involvement, a collaborative approach, and expertise in a range of research methods. Her research focuses on a range of under-recognized health conditions and underserved populations, and has had international, national, and local impact on healthcare and policy. Thank you so much, Melanie, for being here with us today. And just a quick note that there will be time at the end of Melanie's presentation for us to have a bit of Q&A. So with that, I'll hand it over to you, Melanie.
Kia ora, Ragnar. Tēnā koutou katoa, ko Melanie Gibson taku ingoa, ko te matua Māui taku kāinga. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So, hello, my name is Mel Gibson, makes it easy to remember. I am Pākehā, originally from the sunny Hawke's Bay, now living in Wellington, and I lived a long time in Melbourne, Australia, which is how I came to be involved in this work. My pronouns are she, her, and I have a background in reproductive sciences and reproductive biology, and so have been a long-term fan of sexual wellbeing Aotearoa, and it's really quite a thrill to be here with you today. So thank you so much for the invitation. Today I'm going to talk to you about the international guidelines for polycystic ovary syndrome, or PCOS. And this body of work was a partnership between the American Society for Reproductive Medicine, the American Endocrine Society, the European Society of Human Reproduction and Embryology, the European Endocrine Society, and the Centre for Research Excellence in Women's Reproductive Life in Australia, which is funded by the National Health and Medical Research Council, kind of our equivalent to the Health Research Council here. So those are the, I guess, the disclosures about funding and partnerships that contribute to making this work happen. First, we're going to start with a little bit of background about polycystic ovary syndrome. Often you'll hear it called a common hormone condition, and it affects between 10 to 13% of women, and it's characterized by high levels of androgens. And androgens are a type of hormone, which are chemical messengers, and hormones act all through different parts of your body. Examples are insulin, estrogen, and androgens. And the brain and the ovaries release hormones that are particularly relevant to polycystic ovary syndrome, and these determine when to release an egg from the ovary and when someone's period starts. So, in PCOS, these high levels of androgens mean that eggs don't develop fully and they don't get released as often from the ovary. And so this can be characterized through or observed by women and people who have periods as irregular periods. And the implication of these eggs not being released is that it can take longer to get pregnant, and it may need medical support in order to become pregnant. But it is not a life sentence of infertility, which is in the past something that some people have been told about PCOS, and one of the myths that it's really important to bust. These high levels of androgens also cause other impacts for people, including increased hair on the face or body, acne, sometimes losing or thinning of hair on the head, and these androgens can show up in high levels on blood tests as well. The other kind of feature of polycystic ovary syndrome is what we call polycystic ovarian morphology, which is where these polycystic ovaries can be seen on ultrasound. But big problem, the real myth related to the name of the condition is that these polycystic ovaries are not cysts. They are sacs of fluid, little follicles with the immature eggs inside. So these are the eggs that don't develop fully and don't get released from the ovary, and they sit in the ovary and build up and build up. They're not cysts. There is no known link with pain or these true ovarian cysts or ovarian cancer in polycystic ovary syndrome. And certainly there's quite a move now, an international movement to change the name of the condition. And I'd expect to be seeing quite a lot more media about that coming up, as it's commonly thought that the name of PCOS is quite an impediment to fully understanding the condition, giving it the recognition that it should have, and improving the way that both people affected by the condition, healthcare providers and policymakers understand what this condition does and doesn't do. So how does PCOS affect people? Historically, the focus of PCOS diagnosis and management has been around the reproductive years and fertility. This has continually shifted over the last 20 years. I used to say it had shifted over the last 10 years, and then I realized how long I'd actually been working in this area, and now I have to say the last 20 years. Anyway, PCOS is now understood to affect people across the life course and to have different impacts at different life stages. And this means that we're taking the focus off the ovaries and off fertility for the condition as a whole, and putting the emphasis on a person-centered approach to management and care, and acknowledging or increasing the recognition that PCOS will often require a multidisciplinary approach over time, and people will need different things at different stages in their life, depending on how PCOS is affecting them at the time. There have been, anecdotally, people talk about it taking a long time to be diagnosed, feeling like their concerns about the condition are minimized or not taken seriously unless it relates to fertility. Historically, people have been told, oh yes, you probably have PCOS, go on the pill, come back when you want to have babies. Or, oh yes, you have PCOS, you won't be able to have babies. And that ignores all the other ways that PCOS can affect people and what is important to people throughout their life. It's all very well and good for me to show slides showing that continuum of how PCOS can impact people, but it's much more meaningful when you show the words that other people use who are affected by the condition. And quotes like this help to demonstrate the frustration, the distress, and how the impact of PCOS can be very under-recognised. And this is consistent around the world, not just in Aotearoa, New Zealand. So PCOS management, so PCOS can't be cured, but the symptoms can be improved. And a person-centered approach is now the cornerstone of PCOS management. And that in the short term management, the immediate management focuses on symptoms and how to improve people's quality of life. And over the long term, it's about risk reduction as well. And all throughout, the aim is to help people live well with PCOS and to recognise what's important to them. So moving on from that general background about PCOS to the international evidence-based guidelines. There were guidelines put out in 2018, and those were Australian guidelines. These international guidelines were then published in 2023 and were an update of the 2018 guideline. And you can find them by searching online for Monash PCOS. That's the quickest way to find them. They've been published widely in a number of different journals. But then there's this full document here, the guideline itself, available from the Monash website. There is about 6,000 pages of evidence and evidence synthesis and systematic reviews that go into this. It's an evidence-based guideline, meaning that it's largely based on systematic review, evidence, and a very strict process using the grade framework. There's also been a publication more recently that's come out of this work about research priorities for PCOS. So anyone who's research active, that's an interesting one to read. And also this guideline has been adopted by NICE in the UK. And it's the first time that NICE, which is the peak UK health body, has formally adopted and adapted a non-UK clinical guideline. So that's a testament to the quality and rigour of which this was conducted with. But not only that, this guideline is accompanied by free resources online in 12 to 15 different languages. So from the beginning, it was the vision was for it not just to be a guideline for healthcare providers, but a guideline for people affected by the condition as well. And so this is one of the reasons why this guideline is so different. It's very ambitious in terms of scope and aims, as you can tell by the number of pages of evidence synthesis, the number of questions that it aimed to answer, and the global reach that it aspired to have. So the number of professional bodies that have been involved in partnering to develop and deliver this guideline shows a commitment around the world to improve care for people with PCOS. It was ambitious because it is written for people with PCOS as much as healthcare providers. So all throughout, we were very mindful about the language that was used to keep the recommendations as clear and as publicly accessible as possible. And also keeping the audience in mind that it was going to be people with the condition reading the guideline, and there are statements about stigma and inclusivity as well in this guideline to help with the context of interpreting the recommendations. It was also different to some other guidelines because there was consumer involvement in each of the groups, each of the topic groups, and that consumer voice was prioritized in the consensus meetings that developed the recommendations. So it wasn't just a group of academics sitting around a table making these decisions. It's also multidisciplinary. Each guideline development group comprised different disciplines, both clinical and non-clinical, from around the world as well. We used a very rigorous process, the GRADE evidence to decision framework, and this required every person involved in a guideline development group to go through quite a rigorous training process and to be present at every meeting, to do our homework, to be fully briefed and to come fully prepared and to bring our A game, basically. The standard, what expected was high. It was also different because it included a research integrity assessment. Unfortunately, there's been a proliferation of articles published that contain false data, and this was one of the first guidelines to use a research integrity assessment at the screening and full text assessment phase for the evidence to ensure, as well as we could, that the recommendations were made based on authentic trials, authentic publications, and authentic evidence. Right at the beginning, there was a prioritization process that we went through with consumers and healthcare providers around the world who had input into which were the most important questions to address for this condition. So we like to say it was evidence, not eminence. And this is just a list of the different partners that were involved in different stages. There were about 35 collaborating and engaged professional societies, consumer advocacy and support organisations internationally. I do want to note up front that this is not an Indigenous-led guideline, which is important in the context of Aotearoa New Zealand. Many experts and patients from different areas around the world and across many cultures and countries got together for this, but it was not Indigenous-led. And stakeholders from across 5 continents were included in the consumer input into the guideline. And also important to emphasise that culturally safe, person-centred care should be at the heart of every management approach. So the patient's symptom experience, the impact on their quality of life, their key concerns and their priorities should guide the management and decision-making. So this was the process, or it's a summary of the process that took place over a couple of years. And it was extensive involvement for the people involved in the guideline development groups, as well as different people coming in at different times to provide the relevant expertise needed. It also included a public consultation phase on the draft guideline before it was fully endorsed by the National Health and Medical Research Council right at the end. And so what did it look like to be involved in this type of process? It looked like this. It looked like Sunday nights, and everyone involved in this work or people in the guideline development groups, we're contributing our time because it's important to be involved in this, and because we want PCOS care to be as high quality as possible. It was difficult being an international process, holding some of the meetings, because we would have our regular catch-up meetings and attendance was compulsory. You could not skip a meeting, and there would be people like me attend here in Aotearoa, New Zealand, attending at midnight or 2 a.m. And then you would have people in the US who, for them, it was the very beginning of their day, and they were up at 4 and 5 in the morning to attend. But it was very collegial all the way through, although a range of attire was worn at different stages. So there were 5 guideline development groups, and they covered these 5 different topics. And I was involved in the psychological features and models of care guideline development group. And you can see on the right-hand side here the evidence to decision framework, which is what we used in consideration before making our recommendations. And you can see that the systematic review evidence was only one consideration in this process. You can see that all of these other components were considered as well, which is very important in an international context. You want to make sure that your recommendations are relevant in many different settings. Sometimes there wasn't evidence. Often there wasn't evidence for all of the elements that we would like to consider, particularly cost effectiveness. But for every question, we did try to consider all of these things. This is an example of what a recommendation could look like. And down the bottom there, you can see the definitions of what an EBR, a CR, and a practice point, what that means. And we were, there's a very standard way to write these recommendations about the term, when we can use the term should, when we can use the term could, things like that. And you also, you can see the little diamonds and little crosses there that show when we were able to make a strong recommendation, or how strong we could make the recommendation, and how certain we were of the evidence for it. If we were very certain about the evidence and we could make a strong recommendation, we were more likely to make an evidence-based recommendation. If there was less evidence, then it could be a consensus recommendation instead. And for local and contextual implementation, we would often have practice points rather than recommendations, to try and acknowledge the range of settings and the adaptability needed for implementation. So that's the process. What was new in the guideline? Well, firstly, there was quite a big change to the diagnostic criteria for PCOS, where the measurement of anti-Müllerian hormone was included as part of the tests that can be used to diagnose PCOS. It can be used as an alternative to polycystic ovarian morphology on ultrasound. So this is really important for settings where access to ultrasound can be difficult or cost prohibitive as well. It's very important to note that AMH is not a single test for PCOS. PCOS is still a diagnosis of exclusion of other etiologies, and it needs to be made in conjunction, it needs to be used in conjunction with presence of irregular periods and hyperandrogenism. And also important to note that if irregular menstrual cycles are present and hyperandrogenism, then an AMH level or a ultrasound is not needed in order to make the diagnosis of PCOS. This guideline also was able to clarify the criteria for diagnosing PCOS in adolescents, and we were able to offer much more clear guidance about that. Serum AMH should not be used yet in adolescents, and ultrasound is not recommended either in adolescents. So that there'd been quite a lot of debate in the field about how to or whether to diagnose in adolescents, and this provides more simple and clear guidance for that. Women with PCOS should be considered as at an increased risk of cardiovascular disease, and that was a new recommendation or a new statement in the 2023 guideline based on newer evidence than had been available in 2018. And also there's a recommendation that healthcare professionals should recognise that pregnant people with PCOS have an increased risk of a number of adverse birth outcomes and complications during pregnancy. Some of the timing for regular health checks was able to be clarified in this guideline, and also some guidance around obstructive sleep apnea, the consideration of that, and a recognition of the increased relative risk of endometrial cancer without recommending routine screening, as the absolute risk is still low. For emotional well-being and models of care, screening is recommended for depression and anxiety in adults with PCOS. For adolescents, only depression, not anxiety as well. The evidence wasn't strong enough for that. This guideline group avoided reviewing the management of conditions such as depression, anxiety, eating disorders, body image, psychosexual functioning, because there are relevant evidence-based guidelines available for most of these conditions. That was out of scope for this guideline. Also, there will be regional recommendations for those conditions, but important to acknowledge that PCOS impacts people's psychological well-being, and these are some of the ways that it can impact well-being, and to be aware of those. Lifestyle management remains the first-line therapy for PCOS, regardless of weight. Although the guideline acknowledged that lifestyle alone can be futile for higher BMI, and the recommendations for lifestyle management are in line with the population guidelines. There is no one diet recommended over others, and that's really important in the TikTok age, the age of influencers, where the internet and social media is just flooded with the PCOS diet and the PCOS exercise program, the PCOS weight loss program. Cure your PCOS with this physical activity program. It's not there. The evidence does not support one way above any other way, and so it's really about developing the goals and promoting healthy lifestyles, taking care of psychological well-being, and referring to dietitians or exercise physiologists for further support in individual cases. For pharmacological therapy, this needs to be led by a patient's concerns and priorities, and they can include the oral contraceptive pill, the oral combined contraceptive pill, No particular preparation has been found to be superior, and the recommendation is to use the lowest possible dose. Metformin is recommended for metabolic features, but not in pregnancy. For the first time, this guideline was very clear about recommending laser and light therapies for the treatment of hirsutism because of the impact that it can have on depression, anxiety, and quality of life for people with PCOS. And this was something that has come through very strongly from consumer advocacy organizations and is now recognized by health professional bodies as well to be incredibly important to people affected by the condition. For infertility, the algorithm has been simplified, and it's important to reassure people with PCOS that pregnancy can often be successfully achieved, either naturally or with assistance. A lifelong reproductive health plan is recommended, including preconception health, healthy lifestyle, prevention of weight gain, and optimization of fertility. Letrozole is the first-line pharmacological treatment for or therapy for infertility in PCOS. And then the second-line therapies include clomiphene citrate, gonadotropins, and ovarian surgery. When other ovulation therapies have failed, then in vitro fertilization is offered as a third-line therapy, not a first-line therapy. So it sets out very clearly the steps to take there. Tools. Information is a high priority for people with PCOS. It comes through the literature again and again and again, particularly at diagnosis, and providing reliable sources of information to everyone with PCOS is recommended. And so this guideline was accompanied by a whole range of resources online, including webinars, videos, animations. There are tools specifically for GPs. There are short courses for healthcare providers. We developed an app which has been downloaded, I think, about 100,000 times. It includes a question prompt list to help people put their questions about PCOS into words and to facilitate that shared decision-making, two-way communication with their healthcare providers. So again, it is not designed to be a guideline just sitting on a shelf, but something that is there for the whole community. And I think that brings me to the end of my slides. So yeah, thank you very much for having me. Again, I'm happy to take questions. Oh, I should probably definitely acknowledge that no one healthcare provider is expected to cover off all of those things, everything in the guideline in one visit or at all. It is expected to be something that people dip in and out of depending on the person in front of them or the people with PCOS, depending on their primary concern at the time. That will change over time, over the life course, but no one's expected to do it all. Thank you.
Wow, thank you so much, Melanie. I am really struck by the just incredibly comprehensive, rigorous approach that it sounds like you and your colleagues took in doing this. And I only wish that there was such, and maybe there are, and I'm not aware, but sort of companions for other reproductive issues. I feel like it would be great to have that sort of attention and focus and commitment. I mean, it just sounds like it was a lot of time and effort on your part and the other people involved. I have several questions, but I'm going to ask if people are able to turn on their cameras. If you could do that, that would be fantastic so we can all see one another. If you can't, that's fine as well. Does anyone have questions that they would like to pose? Yes, I believe that that's Joe who just raised their hand. Joe Lambert.
Kia ora, aroha mai for sitting in my car, but you know, we do what we can to get the mahi done. That's amazing, Melanie. Thank you very much for that as Ragnar just said, very comprehensive review. Take off my sunglasses. I just wonder what the age is defined for adolescents. Is it World Health Organization 20? Yeah, that would be.
Yes. Do you know, I knew that as I was saying it, I thought, you know what, I can't remember what that age is. I really hope someone doesn't ask me that. Because it's been a little while since I revised my knowledge of that. Is yes, I think it's the WHO criteria, but also it depends on the number of years post onset of periods as well. I know that that was taken into consideration as well. So I am going to refer you back to the guideline for that full definition. I am so sorry.
Sorry, anybody else have a question they would like to pose to Melanie? Yes, Caitlin. Caitlin, you are muted. I think you might be having some connection issues. Are you there?
Yep. Oh, Caitlin? No.
I think Caitlin might be frozen. If you want to put your question in the chat or try again, just let me know. Anybody else have a question they'd like to ask?
Kia ora, not a question, just to say that that's an awesome presentation, Mel. Really enjoyed it. Have gone through some of that stuff too. So that's why it was sort of on top of having a listen to your presentation. But beautiful presentation, and thank you very much for the research that you've done for wahine. Kia ora.
Kia ora, Tina. Lovely to see you. Thank you for coming. But definitely PCOS is, like so many places around the world, it's under-recognised in Aotearoa, New Zealand. And definitely the voices of wahine Māori have not been heard on this issue for sure. There is a lot of mahi to be done here about PCOS.
Yes, thank you, Tina. Rin, am I saying your name correctly? You have a question?
I was curious whether, I'm not sure if this would have been part of the scope or not. I was curious whether how the impact of COVID-19 on PCOS might have been considered as part of the framework.
Yeah, that's a good question. I'm thinking about the timing. We started the evidence reviews, I guess, post-COVID for, or post that very intense COVID phase. But definitely I think the evidence about the impact of COVID on PCOS will be still emerging, because there's such a lag between collecting the data and publishing it, and then there being a body of evidence around that. So no, it wasn't considered simply because of the timing in this guideline. I would expect that if there was another update, and you are supposed to update it every 5 years, that there would be more of that comes out in the next round. So, but really good question. Thank you.
Thank you, Rin. Anyone else? I have a question for you. I was really excited to hear you say that this was a more person-centered approach, and hearing about all of the different voices that were brought in and really considered through the review process. I was also curious about the focus on the metabolic health, and I was wondering if you could speak to that a bit more. And I guess I'm saying this from understanding more and more. It seems like there's every day more communication and evidence around the importance of metabolic health for all facets of health, whether that's Alzheimer's or something else. So I'm just curious if you could talk about that a little bit and sort of how PCOS, what effect it has.
Sure. Being being a endocrine condition or hormone condition, PCOS is going to have that, does have a metabolic impact through its interaction with insulin as a key hormone. And there's a complex interplay with weight and BMI as well. And there's also been, we're still playing catch up a little bit in PCOS, where because it has historically been considered a condition that only affects people in their reproductive years, because the focus has been on achieving fertility in treatment and seeing women and people who can get pregnant in that very narrow way, means that there has not been a lot of research conducted into the impact of PCOS after the age of 35 almost, and what happens in perimenopause, menopause, postmenopause. We're only just starting to have enough evidence to back up the not the feeling, that's not right, but it would make sense, knowing what we know about insulin and diabetes and metabolic impact, that PCOS would have an impact later in life and on cardiovascular risk and heart disease, but it's only recently that evidence has really started to emerge. So in the 2018 guideline, we could not say that people with PCOS were at an increased risk of heart disease. We could say that in the 2023 guideline. So, there's always that classic interplay of sexism and ageism in research, right?
Indeed. I'm always
We're still combating that too, because of course it's an evidence-based guideline. We can only talk about what there is evidence for. So that's a constraint that we're working within as well. Yeah.
Yes, absolutely. And along those lines, I'm always struck by those charts which show, global health funding and how this 2% was the last one I saw that addressed issues of women's health versus, I don't know, it's like 45% that's specific to men's health. So just continuing to have that challenge overall. I want to open the floor again if anybody else had another question, because I do have another one for you, if that's all right. Anybody else? Okay, well, you can think for a second too. We have a bit of time. But I was curious when you talked about the adverse birth outcomes, and I don't want to focus on this because I appreciated your very positive message that I think is a big one for people, which is that you may still be able to, that there are various pathways you can pursue to have a healthy baby from, even if you have PCOS. I think that's such a kind of entrenched idea, I think, in pop culture, that if you do, that you will have major fertility challenges. But I was curious about those adverse birth outcomes and kind of what shape those took or what those might be. And if there was any kind of intergenerational aspect that you're aware of.
Yes. There is a growing body of evidence that there can be a genetic and familial tendency or risk for PCOS, and so there can be an intergenerational occurrence in that way. Again, this requires in a field where a lot of people have gone undiagnosed, getting that intergenerational evidence is still emerging, I would say. Considering people with PCOS as having high risk pregnancies is something that's starting to become more well accepted. It's not just a case of making fertilization happen for people. It's about achieving and ensuring a healthy pregnancy all the way through. And so people with PCOS do have an increased risk of higher gestational weight gain, of miscarriage, gestational diabetes, hypertension in pregnancy and preeclampsia, small for gestational age babies, low birth weight, preterm delivery, and cesarean section. And you can see why I don't list all of those things in the on a slide, because that could be really scary and tell the wrong sort of story about pregnancy. And we're talking about an increased risk. We're not saying that all of these things always happen and to everyone. Some of the time, some of these things may happen.
Right, of course.
There's an increased relative risk. Yeah. So it's
thank you
important
for
to
that.
make sure that people are really well linked in with their healthcare providers during pregnancy, and that people who are involved in pregnancy care, such as midwives, obstetricians, have a really good understanding of PCOS and how to care for people with PCOS during that time.
Thank you for that. I got a question from Caitlin, who put in their comment here. So wondering if you had any insight on how consistently the guidelines are being applied in clinical practice, please. I'm doing my master's on the lived experiences of people with PCOS in Aotearoa, New Zealand, and my participants have had experiences that indicated there are huge gaps in the knowledge of their healthcare providers in understanding how to diagnose and treat PCOS.
Yes. I would say that you have the best evidence, the most up-to-date evidence on that. Yeah, and I'm really excited about your master's project, and I'd love to touch base with you about that and hear more about what you're doing. And yeah, I'd love to make that connection. There is a lot of variation around the world in how PCOS is treated and or managed, and trying to track over time the impact of the guidelines and how that influences clinical care is so different, which is why studies like yours about the experience of people with PCOS, particularly in Aotearoa, New Zealand, where it doesn't have as high a profile as somewhere like Australia, then that's so important to be doing that work. Yeah, there's been a lot of conversations had over the years about, well, how do we measure what's changed, and how much bias might be in that when if we do measure that. And that's why I think we've focused a lot on reach and like being able to measure and count how many people we have reached with particular resources has been really important, because it's really difficult to measure that in clinical care. And also recollections may vary between healthcare providers and what's documented and what consumers of healthcare feel like they've received as well. So really thorny question.
Thank you so much. I don't know if you can hear me. Sorry about the network issues I was having earlier, but thank you for answering my question. Yeah, it's something I'm really passionate about as someone who has PCOS, but also as a researcher. So yeah, thank you so much for your talk today and for answering my question.
No, thank you. Email me, let's connect.
Lovely, thank you. And sorry, Caitlin, I think I was missing that you were trying to ask before, so apologies. Claudia, I don't know if you'd like to ask this yourself, but you're raising the issue of GLP-1s and how the effect of GLP-1s as an alternative to metformin. Is it metformin?
Metformin. I am actually absolutely not across that. I can't comment on that, and it's important to know when you can't answer a question, and I don't know about that, sorry.
Okay. Well, I think Brenda has asked a question. Can you advise on what level of AMH is sufficient for the diagnosis? Is it a level in the top 10 percentile or the top 20th percentile or something else?
Yeah, I'll refer you directly to the guidelines for that because all of the criteria will be in there for sure, and give you good guidance on that and how to interpret that in the context of other the other tests that need to be done as well.
Yeah, can I just open that up because I have looked at the guidelines and I don't think it's clear. So it's just something I've never quite understood from the guidelines. So I wondered if anyone else knows. Because it just says elevated. So I don't know if we take above, the average or different percentiles. But anyway, that's just something that's not clear.
And always feel very, please feel free and confident to contact the people who were involved in the guideline. Everyone is listed in terms of who was in each of the guideline development groups, who the project sponsor and lead was. Always feel free to reach out for clarification as well, for sure.
Okay, thanks.
Thank you, Brenda. Joe, do you have another question?
Always have questions. You know that. Kia ora. Brenda, who asked the last question, and I both, well, Brenda's the chair of the New Zealand College of Sexual and Reproductive Health, Melanie, and I am chair of the Education Committee. We have a webinar series, we have some newsletters and things. How can we promote these guidelines better? Our members are all clinicians, midwives, nurses, nurse practitioners, doctors who work in sexual and reproductive health, I think. So we can do all of the above, or yeah, would that be useful? So you may get an invite from, I'm not in charge of the webinar series, but would that be, I think Brenda, would our members be deeply interested? Yeah.
I would love invitations. I will speak about PCOS in any forum that I'm invited to, and I will have answers to the questions that you asked this time, and then you'll ask me different ones next time. But I promise to do my homework on the things that you have asked about. Yeah, you're right. It's an absolute, I want to use the word scattergun, and that's not quite the right word, but you need to try and reach people in as many different ways as you can. And while you can have those kind of static resources available on a website, such as the videos and podcasts, and all of those things can be really diverse ways of reaching people, but you also need all of this in-person stuff where you need to be able to have a korero with someone and to be able to ask those questions and hear a 20-minute summary rather than read everything in that type of document. So absolutely, the more opportunities, the better.
Good. And also, I think in our using those guidelines, applying it to our local context is really important as well. As you've already said, this is international, and also thank you for including our consumers. I haven't heard of many other guidelines that have done that, but that's probably my own ignorance. But I think that's just amazing for consumers as well to have input into these guidelines. So, ngā mihi nui.
Kia ora, kia ora. I don't think it is the norm, but I think you probably go through you have different korero when you have people affected by the condition in the room, and you have that in the moment accountability. I think that was really, really powerful in the in-person days that we had. Yeah, to keep the person front and center of the guidelines at all stages. Kia ora.
Wonderful. Well, this is very exciting to me that now we could have Melanie presenting in another forum on this topic. And this is just why I like to organize this webinar, is to create a community of practice and bring people together and think about how to, continue to provide this branching network so that we're all learning from one another and understanding all of the great work that is happening. So I want to thank everybody for their fantastic questions and comments. And a huge thank you to you, Melanie, for taking the time and walking us through that. I think having that breakdown of the process as well as the recommendations was fantastic. And as I said, really inspiring for thinking about how this could be done for other sexual and reproductive health conditions. So just really appreciate all of your work over those many months or even years that took place. And with that, I think we'll do a closing karakia.
Kia ora.
Kia tau, kia tatu katoa. Te atawhai o tō tatou ariki a ihua kara iti. Me te aroha o te atua. Me te whiwhinga tahi tonga. Ki te wairua tapu. Aiki, 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 amine. Thank you all so much for your time and hope to see you again at one of the webinars. Ka kite.
Kia ora.
Thank you.